This is another Puscast, a review, or more like an overview, of the infectious disease literature that was published in the first 2 weeks of February in the year 2021. References are available at EduDoc, the home of my multimedia empire, as well as links to those things of interest in my multimedia empire. Not much else to tell you, so let's get on to the literature, shall we? And what will likely be a fixture, we start with COVID-45. And there are a tremendous amount of articles out there. So let's see what may or may not be of note. One of the topics that I'm interested in with COVID is antibody production. When does it occur and how long does it last and under what circumstances? And I think I'm about to give up on that. When they occur seems to be fairly well described, but how high the titers get in what population and how long they last tends to be multiple contradictory or at least different studies. And I'm going to wait until somebody far smarter than me puts them all together for a review article. For example, there's a New England Journal of Medicine article that suggests having high levels of anti-spike or anti-nucleocapsid IgG directed against COVID results in a marked decrease in a COVID infection in the next 6 months. But who cares about 6 months? I'm more interested in 6 years or 10 years, and hopefully I'll be alive and caring about the answer at that point. Well, actually, probably not. I'll certainly be retired, although hopefully not dead. And part of the problem with these studies that different assays mean different things. So as this Journal of Infectious Disease article points out, that some antibody assays are better for surveillance, where others are better for predicting whether or not there is neutralizing antibody. And yet another study shows that those who have mild illness get a fairly rapid decline after 60 days in their antibody levels. But what this means clinically is uncertain. So there's too much heterogeneity in the antibody studies at this point for my feeble brain to know how best to interpret them as a clinician. A pair of studies that demonstrated what shouldn't do anything didn't do anything. So in patients with COVID, quote, no improvement in survival or other pre-specified clinical outcomes was conferred by treatment with azithromycin in patients admitted to the hospital with COVID-19. And a similar study using chloroquine in patients who were exposed to COVID showed it did not prevent disease. What a surprise. Medications with zero biologic plausibility don't work. Water wet, fire hot. So having a cardiac arrest is never a good thing, but it is even a worser thing if you have COVID. This retrospective study of all the patients who had an in-hospital cardiac arrest demonstrated a 100% in-hospital mortality. And this was independent of baseline comorbidities or this presenting illness severity. So unfortunately, if the patient is sick enough to progress to a cardiac arrest, they're not going to survive it, which is sad, but at least does inform our conversations with family about code status. One of the interesting things that has happened with COVID has been a decline in a lot of other infections, predominantly influenza, but other child respiratory illnesses have declined this year because people are staying home and wearing masks and not spreading the disease. However, I think this is kind of cool in an awful way, or awful in a cool way, did not apply to dengue in Singapore. So when people go to work in Singapore, they work in air-conditioned offices and are not exposed to mosquitoes. By staying home, they were staying in places that did not have air conditioning, and so were exposed to more mosquitoes. And as a consequence, dengue went up secondary to social distancing measures. The social distancing measures in Singapore led to a 37% increase in dengue from baseline. That's not a problem here in the Great Pacific Northwest, but places like the American South, which has more potential for diseases such as dengue, yellow fever, chikungunya, could conceivably see increases in those diseases come summertime if our social distancing remains the same. And as the year progresses, if we get yet another outbreak of COVID due to the more transmissible strains and people stay home, if we'll see a spike in West Nile or not. These are the curiosities that make ID fun in an awful way or awful in a fun way. That's the sad thing about being a physician, is that so many things that are intellectually cool are at its heart the result of human suffering. I have mentioned Newton's second law of the medical literature many times. For every study, there is an equal and opposite study. There have been multiple studies, half dozen maybe, to suggest an increased risk for invasive aspergillus in patients with COVID. This study suggests maybe not so much, and that their analysis suggests that it was more often colonization, 17%, versus invasive disease, which is about 5%. So 3 times as many patients with aspergillus will be colonized than have invasive disease. Still, 5% is a lot, but you can't just let a positive ET aspiration for aspergillus be enough to institute antifungal therapy. I'm not going to pretend to understand pulmonary physiology. And I still think the loop of Henle is a myth. Never did understand how urine gets concentrated with that damn loop. That being said, there's another review on why there's nothing surprising about silent hypoxia in patients with COVID, how patients can have markedly decreased PO2s yet be minimally symptomatic. I read the article, and the bottom line is that's the way physiology works, but I'll be damned if I can remember it when I'm done. And I don't even think nephrologists understand the loop of Henle as I think about it. And what could be worse than having to listen to Hotel California over and over again? See, Don Henley, musical loop. There was that study out of Kansas where they looked at the results of COVID in counties that had masking versus counties that did not have a lot of masking. And you may remember that those that masked had less COVID. What a surprise. In a similar study out in MMWR, they showed that compared to the preceding month, once they started wearing masks, COVID growth rates fell by almost 6%, 5.6 to be exact. Well, I guess that's not almost 6%, that's almost 5.5%. But the bottom line is when people wear masks, COVID isn't spread. And there is more and more out there on the number of cycles it takes for a PCR to turn positive and its prognostic indicator with COVID. So when they do a PCR, they have to run cycles. The fewer cycles before you detect COVID, the more genetic material is there. The more cycles you have to run before positive, the less genetic material is there. So it's kind of a viral load surrogate. One way to be reassured that someone who's still positive after, say, 2 months after their COVID is to ask the lab how many cycles needed to be run. And if it's a ton, then you know it's probably unimportant. This study looked at the outcomes of patients with COVID and found that those that had lower cycle thresholds had worse disease. It would be interesting to have that reported routinely, but unlike a viral load with HIV, there's not much you can do about it. The other thing which was associated with worse outcomes was duration of symptoms. And if you came to the hospital with less than 3 days of symptoms, you were going to do poorly. But that's fairly unusual. I would bet the average duration of symptoms when people hit the door in my hospitals is like 8 or 9 days. It is usually a slow illness. There seems to also be a new pattern in the literature that somewhat puzzles me. It's a form of spin that you find in the conclusions. So this was a study of convalescent plasma in patients with severe COVID. And they found, quote, and this is the conclusion, was safe and showed a non-significant association with study outcomes, end quote. I always thought that if it showed a non-significant result, the conclusion was it didn't do squat. I mean, I know that's a little overstating it, but there's kind of a spin there that I find annoying. And there's a lot more of it in the conclusions of articles of late. And when you look in the study, the p-values are crap. 0.5, 0.13, 0.3, 0.17, 0.94. Come on, please. The conclusion should be, based on this study, convalescent plasma didn't do crap, which they admit to in the discussion. Quote, no significant clinical benefit in either the composite or worsening oxygen support and mortality or mortality alone was identified during the 7-day follow-up. No significant clinical benefit. So why spin the conclusion of your abstract like it's doing something? I don't get it. And another article in the Annals of Stupid Conclusions was a clinical trial that looked at the significance of mediastinal lymphadenopathy in patients with COVID. I've had one patient I can think of whose CT showed a lot of mediastinal lymphadenopathy and couldn't find any good reason for it. Though we fretted a lot about it, the patient eventually did fine. In this study, they found that patients who had mediastinal lymphadenopathy had a poor outcome and were more likely to die. And so these radiologists concluded that everybody needs to have mediastinal evaluation who has COVID. Why? What are you going to do with the result? Nothing. Does the patient need the radiation? No. Does the patient need the cost? No. Who benefits? Well, a radiologist who reads a study. If you found the result serendipitously, because you got a CAT scan for a reason that the patient actually needed one, well, that would be interesting. But no, everybody does not need a CT of the chest to determine whether or not they have lymphadenopathy for purposes of risk stratification. God, I can't believe these things get through the review process. 2 studies out to suggest that remdesivir doesn't do anything. One is a, quote, Bayesian reanalysis. And while I am a fan of Bayes' theorem, it always makes my head hurt. And I remind myself that I took and dropped statistics 4 times in college. I just do not have a statistical mind. I always found the rest of mathematics to be fun and simple, having been a physics major back in the day. So I did a lot of math, but something about statistics gives me a brain freeze. But their Bayesian analysis suggests that remdesivir doesn't do anything. And a New England Journal article looking at the WHO studies found that the following drugs did nothing for mortality: interferon, lopinavir, surprise, surprise, hydroxychloroquine, surprise, surprise, and remdesivir. Again, the problem with the remdesivir study is that they didn't document when the medication was started relative to the onset of the patient's symptoms. Most of the patients I see, again, are around day 7, 8. I don't think remdesivir is going to do squat in that population. The horse is out of the proverbial viral barn. Actually, the viral horse is out of the proverbial barn. And the accompanying editorial does talk about the subtleties about remdesivir and the treatment of COVID. And while it may not in studies affect mortality, patients do get out of the hospital a little sooner. And I suspect that if you gave it to people who were sick with COVID much earlier in their course, like day 2 or 3 at the latest, maybe we'd see more of an effect. Outside of HIV, I can't offhand think of any viral illness where you get good outcomes if you delay treatment beyond 2 or 3 days after symptom onset. But I think most of the time, our treatment with remdesivir is probably, like a lot of what we do, medical theater. And there was a perspective in Open Forum Infectious Diseases entitled The Erosion of Public Trust in SARS-CoV-2 Vaccines. More action is needed, where they bemoan the decline in public trust in vaccinations and how we should be doing more with social media. Again, I comment, I wrote for a decade over at Science-Based Medicine, and one of my niches was writing about vaccination for some strange reason. And one of the striking things since the Wakefield article on vaccines and autism has been, for the vast majority of this century, and a little longer, the near complete lack of the Infectious Disease Society of America in combating anti-vaccination. There were never articles for me to quote from the IDSA on anti-vaccination. Our society let this slide forever, and now we're paying the price. People don't trust science and vaccines because the people who got all the press were the anti-vaxxers, and the IDSA was nowhere to be seen. The only person who did any work in that area was Dr. Offit, and his work has been amazing, but that's about it, and he wasn't even doing it through the auspices of the IDSA. However, if I remember right, they worked really hard at getting better reimbursement. I think that's enough of COVID and whining for now. Let's move on to some other infectious diseases. There's more to the world than COVID, believe it or not, like influenza. Back in the 70s, there appeared to be a strain of flu that was going to cause a pandemic. So during Gerald Ford's presidency, which I remember, there was a spike in Guillain-Barré associated with that year's flu vaccine. And it's always been a question as to whether or not the vaccine is associated with Guillain-Barré syndrome. At its worst, your odds were higher to get GBS from the flu than from the vaccine. But the question has been raised whether or not the high-dose influenza vaccine given to us old folks is associated with GBS. And the best they could say is they can't find an association. Quote, the Medicare analysis did not exclude an association between the high-dose vaccine and GBS, but it determined that if such a risk existed, it was similar in magnitude to prior seasons. So the signal, if the vaccine causes GBS, is still very tiny, if there at all. So if the flu vaccine does cause GBS, the high-dose flu vaccine, the signal is on par with gravity waves, and we do not have the ability to detect it. So what would you like to know about rickettsia? Well, one, Rocky Mountain spotted fever is found in Mexico, specifically the Sonora area, as this review finds. And there's large parts of Mexico where the endemicity of human pathogens is not well known or documented. For example, I did see a case of relapsing fever in someone from the Sonoran area a couple years ago, and there's very little literature on the epidemiology of these diseases. There are also a bunch of other rickettsia out there, and under the category of a rickettsia that causes an eschar and a rash would be Rickettsia honei, Honei. And there's a case of a patient who presented after returning from India in the Himalayas with that particular rickettsia. New rickettsia seem to be multiplying like bunny rabbits, although I don't really know how bunny rabbits multiply. But any weird fever in a traveler mandates a quick Google for rickettsias and spirochetes and other organisms that are not easily grown but are ubiquitous in the world. And they do love to show up in case reports. ID is nothing but evolution in action. If you look at the average MIC, say, to penicillin to pneumococci, the MIC has been slowly creeping up over the last 50 years. Now the same thing is happening with group B streptococcus, aka Strep A galactiae. While it still remains susceptible, there's a slow increase in the number of organisms with reduced susceptibility to penicillin. Only 0.1% were resistant and 0.5% had reduced susceptibilities, but that's more than it used to be. And while not a lot, the slowly accumulating resistance of bacteria to antibiotics is as inexorable as sea level rise over the next 100 years. And yet, in both cases, we're still playing King Canute. I still think we're going to look back on 2020 as the good old days. So, who gets invasive pneumococcal disease? Well, people with liver disease and alcoholics, and people with issues with their immunoglobulins, such as Waldenstrom's and myeloma. But as this article notes, also patients with cancer, especially hematologic malignancies, who have a markedly higher risk for developing invasive pneumococcal disease, but they have an absolutely crappy vaccine uptake, with less than 2% of patients with hematologic malignancy in this study out of Denmark having been vaccinated with the pneumococcal vaccine, and 1% for those with other types of malignancies. So the take-home message is not only that people with hematologic malignancies at increased risk for developing pneumococcal disease, they are completely bypassed on getting vaccinated for what is a quasi-preventable illness. We often send people home from the ER after blood cultures have been obtained, and sometimes they pop positive after discharge. Is that a bad thing? In this study out of Israel, the answer would be no. Patients who were sent home who subsequently had positive blood cultures tended to do well. Most of those who were not admitted had a urinary tract infection, and a surprising number, this being the Middle East and all, having brucellosis, not a common issue here in Oregon. The other interesting thing is that half of the patients who were sent out on antibiotics were sent out on the wrong antibiotics. But generally speaking, if a patient is sent home pending blood cultures who are clinically stable, they tend to remain that way. If I had to make a guesstimate, I would say maybe half my liver abscesses, not me personally, but in my patients, are due to Klebsiella pneumoniae, often the hypermucus, hypervirulent organism. And they can be a son of a gun to take care of, responding slowly to antibiotics. If your Klebsiella pneumonia liver abscess should happen to have an ESBL phenotype, that is associated with increased recurrence of abscesses. What kind of recurrence? 18%, which is pretty hefty. Again, I find it puzzling to have that high a recurrence rate. I don't think I've had a Klebsiella liver abscess recur, and I've had a smattering of ESBLs. On the other hand, this was 110 patients, and I've probably seen, 10 tops? So I just haven't had time yet to get my first failure/relapse. So a normal spinal tap is 4 or less white cells. What do you make of a patient, though, that has 5, 6, 10 WBCs on their spinal tap? This study looked at the outcomes of them would have 5 to 10 cells, leukocytes, on their CSF, and about 5% of the time they made a diagnosis. Now, this study was out of Europe, so our or your mileage may vary, but the diagnoses they made for patients who had 6 to 10 white cells on their spinal fluid were 1 rat bite fever, 1 HHV6, 1 pneumococcus, 3 cases of enterovirus, and 5 cases of tick-borne encephalitis. So out of 178 cases, 5.6% had a diagnosis to account for their elevated CSF pleocytosis, 6 to 10. We don't have any tick-borne encephalitis here in the Great Pacific Northwest. I've seen but 1 case of rat bite fever, and so that leaves enterovirus and perhaps pneumococcus as potential etiologies. I suppose the take-home is 6 to 10 is abnormal, and there is a chance you might make a diagnosis of something, but not very often. A study out of Clinical Infectious Diseases looked at the issue as to whether or not an isolated white count was worthy of ordering a C. difficile, and the answer is no. You should not do C. diff testing for either a high or a rising white count unless you have some other gastrointestinal reason to order a C. diff. But a white count alone doesn't cut it, even if it's rising. So, who dies of Candida endocarditis? Surprisingly, it was those with acute liver failure, but not those who had opiate abuse, where it was protective for dying of Candida endocarditis. The authors did not have a good reason for why opiate addicts were more likely to survive their Candida endocarditis. Being younger and ostensibly healthier did not pan out as a reason for better survival. So maybe it was a spurious finding. What's the best drug for treating invasive aspergillus? I don't know. It's an azole. One of the striking things of the 30-some years I've been in practice is before the current azoles came out, it was rare to get a patient with mucor or aspergillus to survive. Now it's rare, I have found, to have one expire from these infections. This study compared posaconazole versus voriconazole for treatment of invasive aspergillus and found that posaconazole was non-inferior to voriconazole, but did have much fewer side effects. And the hallucinations that occur with voriconazole, the hyper-real dreams that people get, are not insignificant. So, as best you can tell, they are of equivalent efficacy, but the nod goes to posaconazole for fewer side effects and need to discontinue from same. And with mucor, who knows? I mean, you'd go with posaconazole, but what is the optimal therapy? For years, it goes back and forth as to whether or not combination therapy is the optimal approach to invasive mucormycosis. This retrospective study in patients with hematologic malignancies and transplants suggests that the combination of amphotericin plus one of the newer azoles may be the way to go with mucor. Again, I don't know. The literature has always been messy, but when you get a mold like mucor invading into some vital tissue, I don't see anything wrong with throwing the kitchen sink at it as well as surgical debridement. Although it ain't cheap to give someone posaconazole and lipid ampho. Lipoarabinomannan is a cell wall constituent of tuberculosis, and it comes out in the urine. And this study out of Africa suggested that it's a useful test in HIV patients for looking for patients who have tuberculosis. I had never heard of lipoarabinomannan testing, and it doesn't appear to be offered by our referral labs. But looking in the literature, it appears to be a promising test. The sensitivity can be quite low, but given our crappy ability to diagnose active tuberculosis, I'll take anything that comes my way. And if I have a test that is positive only 5-10% of the time in people with active TB, I still go for it because it's nice to know. But as best I can tell, it's not a test I can order in my hospitals. But in HIV patients with low CD4 cells, it appears to be a reasonable screening test. Babesia is increasing in the United States, in the American Northeast, which may be a consequence of increased awareness and increased testing. Also, it appears that its range is increasing. There are now cases being found in places that are not considered to be endemic, including California and Florida. So Babesia may be more widespread than we have previously been aware of. And also the range of the ticks is changing with global warming. And with these ticks go tick-borne illnesses like Babesia. So like so many infections, the geographical range is changing dramatically for Babesia and other infections. So there was a case also of a woman who was born in Venezuela, came to the United States at age 20, never went back but once. In her 80s, she developed an autoimmune disease that was treated with prednisone and azathioprine, and her Chagas disease came back, presenting with red bumps on her legs. The take-home of this particular article is that Chagas can reoccur with immunosuppression decades after the likely initial exposure. And does gowning and gloving help? This study looked at the benefits of universal gown and glove for the prevention of acquisition of antibiotic-resistant bacteria. And they found it didn't help. As they say at the end of the article, quote, in conclusion, the association of universal glove and gown use in the ICU with the acquisition of antibiotic-resistant gram-negative bacteria was inconclusive. The organisms they were interested in were carbapenem-resistant Enterobacteriaceae, carbapenem-resistant Acinetobacters, carbapenem-resistant Pseudomonads, and ESBL-producing bacteria. I remain of the opinion, outside of outbreaks, that outside of hand washing, gowns and gloves do little to nothing to prevent the spread of organisms because they are ubiquitous in the environment and they are part of the normal human flora. I don't think that isolation works for bacteria that aren't essentially pathogens. You can protect against smallpox, but you can't protect against E. coli. That's my take. And that would be mostly supported by this article. But it doesn't stop them from spinning it, because they say in the conclusion of the abstract, universal glove and gown use in the intensive care unit was associated with a non-statistically significant decrease in acquisition of antibiotic-resistant gram-negative bacteria. Again, I thought non-statistically significant meant the intervention didn't work, it failed. And the p-values across the board were 0.3, where you really have to have 0.005 is probably your minimum p-value for a real effect. But again, they can't bring themselves to say it doesn't work. They have to say it was a non-statistically significant decrease. That seems to be the current way to report negative studies. And that ends this endless whinging about the infectious disease literature by a grumpy old fart in Portland, Oregon. The references to this grumpy complaining are at edgydoc.com, home of my multimedia empire, where you will also find links to my books, my apps, my blogs, my podcasts, my lions and tigers and bears, oh my. And so, nothing else to say, so take it away, Jeffrey.